Well, hi, everyone. Thank you for joining another VITA Learning webinar. Today we're going to have Mark Wagenseil waving there in the background. He's going to speak about the analysis, setup principles, satisfaction of Class 2 removals, which is really exciting because most of the time we talk about Class 1 normal occlusal schemes, the normal stuff that we do every day and throughout the week. But many of us have questions about a Class 2, a Class 3, combination syndrome type cases. And I think this is going to be very beneficial for all of us to learn more insight into the clinical aspect as well as the laboratory aspect. Mark Wagenseil is a denturist, so he kind of does both. Let me cover a couple of the housekeeping things. Your phone's going to be on mute, everyone. So if you have a question throughout this webinar, go ahead and use that panel. That panel is located on the right. And in there is a question box that you can certainly type into and send me a question. Otherwise, we will have a Q&A, question and answer session at the end of the program as well. But just to get started, send me some questions. If it's something that Mark is talking that needs to be answered about that time, I'll interrupt Mr. Wagenseil in his very professional presentation and stop him and have him answer your question. The webinar in itself is also going to be recorded. So if you want to revisit it, you can just join us on our VITA North America YouTube channel or website, LinkedIn, and so forth. We will post it. Give us a couple of days after this is over, it'll post, and then you'll be able to review it or review it with your team on all the things that, marvelous things that Mr. Mark Wagenseil is going to give us all, talk to us about. So again, we are working with Mr. Mark Wagenseil. He is a denturist, a licensed denturist. He's a VITA Global certified trainer as well, and a management consultant, if you will, for us. He's a licensed denturist, so he just doesn't say he's a denturist, but he's actually licensed. So he's licensed to not drill, but licensed to place his hands in the patient's mouth. Which is excellent for us to learn that clinical experience, because we sometimes lack the clinical experience from a technician's side in the United States, because we often just get bite blocks and things from the dentist, and then we sometimes got to call them up and tell them, hey, we need this and this and that. So this is good information. Mark's been a denturist technician for over 30 years. He owns and operates his own laboratory. It's called Heritage Denture Center in Edmonton, Canada. And he is a, clinical practice. He does multiple things, so he's a good source of information for all of us. Mark also has spent his career focusing on how the dentures integrate into the mouth and body. So Mark does a little bit more than just practical setups, but he he tells us the way it is and makes us understand why we're doing the things that we're doing. Why do we set the teeth up the way they are set up for all these different classifications? So this is good information as well. He inspires a unique awareness of occlusion and professional growth of technicians, dentists, and other denturists. He loves training. He loves getting his hands in the mix. He loves working with everybody. And I will turn it over to you, Mark. So I am going to get rid of my face and then make you the presenter right now. So let's see here. There we go. All right, your
so I have the PowerPoint up.
slide is up. Yep.
I love technology. Awesome. Good morning, everybody, or good afternoon, depending on where you are. Woot, woot. We do not slap teeth together. No. Welcome from a little bit of a colder Edmonton, Canada today. It's 4 degrees below freezing. It's currently snowing a little bit. So we're still having fun up here in the Great White North. So good morning or good afternoon. Thanks for taking time. Thanks for taking time for yourself and investing in yourself and ultimately the patient that places trust in you. So good morning. All right, let's get to it. Our common issues. What do we face with dentures? Denture teeth chip, break, pop off. Patient can't chew well with a new denture. I love that one. My old one works better and fits better than my new one. New dentures are more loose than the old set. Multiple relines, still with no success. Denture base breaks. Food collects under the denture, but you don't need to reline it. Or you've relined it and it still collects underneath it. And then we just get good at saying, well, that's the denture. Denture feels too big, soreness, and the temporary denture is preferred over the permanent one. This causes us stress, everybody, whether you're a dental technician or you're a direct care provider. It's stressful. And now we have to stick in a class 2 jaw relationship, which is a little bit outside of our norm. So it changes it for us. So we want to talk about that today. We want to talk about how to manage it today and to help reduce our stress. It's stressful enough right now, being in practice and certainly interacting with patients. People are a little bit more edgy than what we were a year and a bit ago, especially the seniors. So a lot of them have been shut in. So they need the work done. They have to get it done, but they're a little anxious. I want to review the why before showing you the how. So bear with me. Some of you will have seen this before, some of you not. This is important though, because I want to show you the why before I show you how. Many courses that I've gone through, they go right into showing you how to do it, but very little time spent to say why you should do this. It's easy for me to come here and jump online and show you how to set up a couple denture teeth and then hope you remember to do that in your practice later. I wanted to show you why you need to do it and then show you how. Charles Darwin stated, it's not the strongest of a species which will survive, nor the smartest, it's the one most adapted change. So thank you. I'm here to ask you to change today. I'm going to push you a little bit. I'm going to argue with some of the conventional things that we've been doing. And how I was initially trained, and now 34 years into my career, after banging my head on the wall a lot with patients and being frustrated, have started to try and understand and figure things out a little bit. And that's what I want to share with you today. A little bit about VITA teeth, since that's what we're using today. They follow the square tapering ovoid selection criteria, so it's fairly standard. The teeth are made from a micro-reinforced polyacrylic. This is important. It's 85% polymethyl methacrylate, 4% inorganic filler, and 1% shade. The inorganic filler, or the 14%, is silica. Silica, by definition, is quartz. By definition, is glass. This is an acrylic glass tooth. Why is there glass in it? Well, it's like enamel. So it's the best property we have, like a ceramic, that can reproduce the characteristics of enamel. So they put glass in the teeth to make them like enamel. A couple of key points on that. They certainly look more like real teeth. You have to be careful when you flame them. They have a lower burning temperature, so you have to be careful when you're using a torch, because you can burn the teeth. The big thing is that you don't have to polish them after you grind them. We typically, when you adjust an acrylic tooth or an IPN type of tooth, you have to polish the surface after or it stays rough. Here you don't need to do that. You can use a very fine, very, very fine burr or a very fine stone to grind the tooth, or a rubber wheel even. And then you don't have to polish it after, because it's going to self-polish because of the nature of the material. And that's been key and a big blessing for me as a practitioner, that I don't really have to polish it afterwards. So that's very important. I wanted to share that. VITA teeth have opalescence. So again, fairly standard picture of enamel teeth. So again, VITA puts opalescence into their teeth so that they have more likeness. So the VITA teeth also have fluorescence. That's caused from phosphorus in our enamel. So VITA puts phosphorus and fluorescence into their denture teeth as well. So this picture was taken by a now retired VITA rep in Western Canada by the name of Ken Parker, and he showed under a black light, the left side is glowing, the right side isn't. The right side is Dent supply teeth, the left side is VITA, and that's from the phosphorus inside the tooth. So it glows and acts more like enamel. So the VITA teeth also have the magic triangle for aesthetics. So shape, shade, light. So we call this the golden proportions. So the VITA teeth, so specifically Excel and Physiodens, have the magic triangle for aesthetics. Sorry, my brain is working. Didn't come out of my mouth fast enough. And it's golden proportions, which means everything is mathematically equated through the tooth. So much like our skull is all mathematically equated, the distance from our eyes is in relation mathematically to the width of our nose, to the size of our teeth, width of our teeth, proportion of our mouth. Everything is math. So if I could go back 40 years into myself, into high school, I probably would have told myself to pay a little bit more attention to math. But now, even in dentistry, everything is related to math. And so VITA teeth have our golden proportions. And that's important. So again, everything here that you see is balanced, and they designed it to make it more golden proportion. Because again, the slide of what does the patient want? Patient wants a denture, but they don't want it to look like a denture. I've never had a patient walk in and say, yeah, Mark, can you make it look fake, please? No, they all want it to make it look natural, please, so that nobody knows I'm wearing a denture. So what does that mean? Well, we can still make it light, and you can still use bleach colors, but you can still design it and have the teeth slightly moved or tapered such so that it helps break up the light so it doesn't look like all chiclets standing in a row. And that's really important so that it helps show more individuality to the denture teeth and then to the patient, so it doesn't look as artificial in the mouth. VITA teeth are not mirror opposites of each other. So most denture teeth on the market, there are spitting images of each other, mirror opposites, and VITA teeth are not. They are slightly different, and that's the whole point of it. Although they belong to the same set, they are meant to act a little bit and show a little bit of difference to them, and that's important. VITA teeth, and especially Lingoform and Physiodens, have something called Freedom and Centric. This is going to be a key point as we move into the setup portion of today. It's the flat area within the central fossa upon which an opposing cusp contacts and permits a degree of freedom in eccentric movements, uninfluenced by tooth inclines. So that means that the denture tooth can sit inside the fossa and it can wiggle a little bit. So the denture teeth wiggle, and that wiggle is called freedom. And freedom, everyone, is good. So scream it from me, because remember, I'm really north of most people, because Edmonton's the most northern city in Canada. Freedom is good. All right. Most denture teeth on the market do not have this. They're locked together. Yes, they work in balance. Yes, they function. But when you hold them in centric, there's no room. It's locked right in. And this is something that I've been now keenly aware of in my career, that you cannot do this. You have to use denture teeth that have a little bit of wiggle room within the centric. So the real life example is touching your own teeth together. So touch your teeth together in centric and now wiggle them a little bit. Don't go eccentric. Don't go all the way around. Just gently in centric. You can feel there's a little bit of wiggle. It's about a millimeter and a half, depending on the person, but it's there before you go off into that eccentric movement. It's not locked in. So our own occlusion system isn't locked in with natural teeth. Then why have we been locking it in with denture teeth? This was something that was never taught to me in school or explained to me during the beginning part of my career. And what I was seeing, and this loops back to our common problems, is patients are coming in going, well, why is my new one looser than my old ones? And I'm like, well, I don't know, my VITA's right, and my Centric was right. Well, you don't chew in Centric, you chew in a chew cycle. And so what was happening was the teeth were hitting, interfering with each other because they were locked in occlusion. So why is this important? You need to have a degree of compensation so that you're not always trying to land in precisely the same spot. You don't want to hit and slide on the guiding planes. And so the picture to the left with the arrows is really key here, because the hit and slide is what's causing our problems. It causes the denture to rock, it causes the food to come underneath it, it causes the denture to be loose, it causes the soreness. It's the hit and slide that's killing us. And you have to catch and understand, why does it hit and slide? So again, it's understanding that you have to use denture teeth that have that freedom and Centric in it, and VITA has that. So again, with this picture, you're asking someone to pinpoint Centric. So the black dots that you see is what I overlaid to show, okay, that's where you can place a cusp and have into contact, and then that cusp has a degree of freedom in there. The green is the guiding planes. That's where you don't want the hit and slide. Green means good, so you want it so that it can come in and function and not hit and slide against its counterpart. That's important. And that's important when we go into class 2 or 3 or even all the classes. It's important. Because what you're doing is you're asking a patient to bullseye land Centric every time. You know that's impossible, right? And now we're asking a senior citizen, because most denture patients are over the age of 55, 60. We're building it for an older clientele. What happens when you get older? Your neuromuscular system degrades, the muscles degrade, things aren't as crisp and sharp anymore. And now you're asking someone with degraded tone and neuromuscular stimulation to pinpoint and land Centric every time. Well, gosh darn it, I can't even do that because my natural teeth have freedom and Centric, and now I use denture teeth that are locked in Centric, and I'm asking an older person to be able to land and hit Centric every time. The other consideration is this: you and I, with natural teeth, touch, and our teeth have a nerve to them. We can feel. Our natural teeth feel, and there's a nerve going to our central nervous system that's sharing that information. And we feel that, and it's always being brought back to our central nervous system of where our orientation of our mouth is and our teeth, so that they don't bind. When the teeth are pulled, that nerve is cut and it's severed. And now that patient cannot tell, and the central nervous system of that patient cannot tell where that natural tooth is anymore. And so now when they wear a denture, you have to remember that denture is technically dead to the brain. So how do they know they're landing in Centric? Well, it's muscle memory at this point, because now there's no feedback to the brain going, yeah, I can feel the teeth touch. It took me a while, but I laugh at myself, because before I would ask a patient, well, touch your teeth together. Well, Mark, you idiot, they can't feel their teeth touch together because there's no nerve into those denture teeth. And so I loved it, like, well, just touch your teeth together. Well, how do they know they're doing it? Well, they know from muscle memory. So the muscle learns at a certain height, it stops. But then they also learn on the pressure differentiation of the ridge. So the denture pushes on the ridge and it squishes it. So then they learn that when they touch in Centric or swallow, it equates to this much pressure being exuded down onto the ridge that the denture sits on. And then when they chew, it's a stronger pressure. So then they learn the difference, and the brain learns the difference. And then we go in there and we build a new denture, and that changes that pressure. It's a new impression, a new vertical. We change and alter that pressure perception for that central nervous system of that patient. And then we wonder why there's problems and adaptation trouble afterwards. So this is about denture integration into the body. This is about having it and understanding what the patient goes through, and now trying to understand what a senior goes through and what a senior citizen is going through when they're trying to understand and interpret that information. And that's why, again, you want that degree of freedom so it doesn't hit and slide on the guide planes. That's what's really important here, and has been an eye-opener in my career. So again, I went and I took a picture of VITA lingo form. The red are the cusps. So the red dots are the chewing cusp that goes into the black dots on the bottom. That's the fossa. And then the green, buccal upper, lingual lower, is where you want the freedom, where you don't want the hit and slide on the guiding planes. So that's really important. And then as we move forward with the setup today, it's about putting the cusp, the red, into the black, into the fossa. But I'll show you some tricks as we go. Then what happens is that creates stability because, again, you have a degree of freedom. And remember, everyone, freedom is good. You have that degree of freedom so that they don't have to bite in the same position every time, and they're not then hitting and sliding into position. That equates to better stability on the denture and then less complaints afterwards. So this is what it looks like then on an articulator. As you can see now, I'm wiggling it, and it's wiggling within the fossa. So the cusp wiggles within the fossa. Now we're doing regular working and balancing movements, and then the wiggle. So that's what you were doing for me before with your natural teeth. You were wiggling them in centric before you would go out into eccentric movements. Okay? So it's interesting. I have to say that during my career, you know, we especially thinking back in the early parts of my career, we would be asking patients to touch their teeth together and then slide forward or slide to the left or go into protrusive. Oh my goodness. They can't feel their teeth. And now you're asking them to touch together and slide forward. Well, I can do it because I can feel my teeth. So it's easy for me to orient where I am and what I'm doing. And then, but we're asking a denture patient to do that has no concept and can't feel it. I'm befuddled a little bit, and yes, I just used that word, of why we would actually try to ask a patient to do that, because it's so foreign to them. They can't reproduce that, and their central nervous system can't reproduce that. I want to talk to you about the chewing cycle because this is going to play into it. We all chew into a chewed cycle. This is what it looks like in real life. So I show this video globally. This is us chewing food. So these are natural teeth and a patient. I want you to look. It's not an up and down bite, right? Oh yeah, Mark, my bite's right. Look at the angulation that this patient is chewing at. Most of the food lies in and around the molars, and they're chewing, and it comes in at an angle, and it's actually a teardrop, a variation of a teardrop. So some have a more stark teardrop, more vertical, more horizontal. This is where the hit and slide comes in, because when you're coming in at an angle, you have to have the clearance so it doesn't hit and slide on the guiding planes. And now you have that degree of freedom. I call it a helicopter pad that the patient can land in, into centric. So this is with natural teeth. This is natural teeth working. So remember, there's a nerve to every tooth. It's always being remitted back, and the pulses are going back to the central nervous system, so everything knows where everything is at all times. That way, you don't break teeth. But now you have to think if your denture patient doesn't have this ability and has lost this proprioception. And this is really important. And now this last little video here is good. Watch this one. You see how it's more vertical? Look at him chew. So this is really important because when you understand what the chew cycle is of a patient, that helps you set the teeth appropriately. And I'm going to show you how. So now you say to me, Mark, well, how do you identify that? How do I identify a chew cycle? Okay, well, before when we would do a wax try-in, I would have the patient, count from 1 to 10, 50 to 55, Mississippi, 66, and I'm looking, is the midline right? Is the wet and dry line correct? You look at the smile line. You would look at all the aesthetic things. Now I'm training my eye to look at what does their jaw do, and you actually can see function parameters of the jaw and the chew cycle by having them enunciate. So you're going to see this. The first video that I'm going to show, you want the patient to come in and say the days of the week or the months of the year in English and then their mother language, please, if they have one. And then it's going to move the jaw. So watch this. See the jaw move? I'm going to swing around. So it's swinging out to her left. See it move? Did you see how she spoke and the jaw came forward? Now we check that on an articulator and we do protrusive. You understand that protrusive on an articulator is nowhere near what it was just now in that own patient. And so I'm going to show you some tips to how to identify that. That's already showing me that she cycles a little bit to the left, postures to the left, and then I can set the teeth accordingly and have a little bit more clearance to favoring that side. Look at this patient, same issue, saying again now the days of the week. Look at her jaw. Look at it move. You see it? Whoa, let me run that again. So now I can clear in and put more path and more freedom. So I'm adjusting the guiding planes of the tooth because I know that this patient cycles more to the left and postures more to the left. So what that means is that your chew cycle looks like this. There's flat, oval, circular, ovoid, teardrop, or variations of it. Some look like a D where they, again, function and favor one side. When you can identify that, then you can make those corrections in the lab when you're setting the teeth. The technician has to inform the dentist of what to watch for, and now you can make your own little, what I just did here, your own little true cycle and have the patient and have the doctor circle it. But they need to have the look at the patient. You want days of the week, months of the year, English and their mother language, so that you can identify this and see it, and then you can make that correction or that modifications in the lab when you set the teeth. That's been critical for me. So I use VITA teeth exclusively because they have that freedom and they have that little bit of wiggle room and the freedom, which is good. And then I can alter things and then not have to polish them after. And I can change it and alter it to the patient and to their chew cycle and what's going on in that person. By just spending a little bit extra time by asking them some questions, taking a look at the movement of their jaw, and then see. And that's really important. Okay, so that's again identifying that the hit and slides. So I'm looking at their posturing of their jaw through phonetics to check for that. Because all the words of a language are covered phonetically within the days of the week and the months of the year. So that's why I'm asking for that in English and in their mother language so that I'm identifying that. And then I'm going to show you how to check for that. But right now I'm laying the foundation of the why. Okay. Remember, your average adjustment rate for dentures is 2 to 5 times globally. What does that mean for you or for your doctor? Most adjustments are 20 to 30 minutes in length. Right now, we've added about 10 to 15 minutes for COVID because of the pandemic. So that means extra cleaning time, extra paperwork time, extra time donning and doffing all the PPE that I need to wear for an aerosol procedure. This is added about 15 minutes more. So I actually, on 4 patients, that's an hour. I can see less patients a day right now because we're a little bit more slower with our paperwork and intake to see a patient. Certainly in larger offices, we have to be careful because depending on where you are, there was some capacity limits. But even as those are reduced and we're getting back to normal, we also still don't want to be in a dental office or cause a super spreader event. So we have to be careful. Remember, we're dealing with seniors and they mostly have pre-existing conditions and are a high-risk group. They want to feel safe when they come to our office. So we have to add that time in. What's important is when you look at it and say, for example, you charge $2,600 for a denture, say the lab takes $700, that left the office with a subtotal profit of $1,900. Your overhead runs at about 75%, so I picked 75. That left you a profit of $475. So overhead is your rent, power, utilities, such. 2 adjustments just left you a profit of $275. It's actually less when you consider the room cleanup. And that's running at about $100 an hour when you look at your cost, a billing rate of the practitioner. So you have to appreciate that on that adjustment, and now you've lost 30 minutes. It gets expensive, everyone. 4 adjustments leaves you $75. So all of a sudden things aren't looking so good. when you do the math on this. So we have to cut our adjustment rate down, and that's dealing with the stresses. Remember, one adjustment a day at 30 or so minutes is 2.5 hours a week. That's 10 hours a month. If we can cut that down and be more efficient now, even more so in this pandemic, that's helping us, it's helping our patient, and it's helping our stress load. Because certainly when I chat with the dentists in my office building, it's stressful. We like to think, and when we talk with ourselves, you have to think that every patient is walking in positive with COVID, and that you need to always be diligent to watch what you do about donning and doffing and cleaning, so as you maintain a clean environment and a safe environment. It's stressful and it's tiring. So you want to cut this adjustment rate down. That's part of the business with dentures, and we've all accepted it as, well, adjustments are normal, but we actually can control it and we can get better. So you want to count up your adjustment rate. You want to count it up for yourself. I challenge you to do that, and then you'll get my contact information at the end. Text me and email me. You want to ask your dentist, hey, what's your adjustment rate? And you want to count that up and say, look, if we follow these new protocols that we're going to put into place with the denture teeth, I can cut that down for you. I'm living proof of this. One missed dental appointment requires 2 to 3 more to recoup. That's the golden rule of thumb in dentistry. Well, now just think of that. An adjustment of 30 minutes, you're not making any money. How many more appointments does it take to recoup that lost cost? It's expensive, everyone. So we have to consider that and on the denture teeth that we use as well. So that's why Freedom and Centric reduces denture dislodgement. I wanted to explain why, because now it works within the chew cycle, and it works within counteracting the hit and slide. It reduces the friction and sore spots, and now the adjustment rate, and you can be and have less stress, of course, dealing with those common faults that we have and those common occurrences that we see with denture wearers. Count up your adjustment rate. Go to your top clients if you're a dental technician and ask the secretary, what was the adjustment rate on that? I know of a prosthodontist in the US. He caps his adjustments. He was doing 175 adjustments a month. So he knows how many he does a month. 175, everyone, on a 4-week work schedule. You can do the math of what he's doing every day for adjustments. He does not make money at that. And so now he's very keen to understand, hey, wait a minute, Mark, how do I drop that? Because of course, then we can only do so many a day or so many a week. And then patients are calling in, and then they're frustrated because, well, I can only see you next Tuesday or a week and a half from now. We've ran into that problem here. Patients don't want to wait when their mouth is sore. So if we can drop that down a little bit and we can control it to 0 to 1 consistently, that's what is going to work for us. Okay, it provides superior fit, saves time and money. And that's why I wanted to show you about the chew cycle, understanding the chew cycle, understanding how the teeth function within that. The fact that they've lost their nerves, they can't feel. When you ask a patient, a denture patient, to touch their teeth together, they cannot feel their teeth touch. They're feeling the pressure. This is what provides consistent results. And this has been my journey to try and understand patients and understand what they're going through. And then I mold myself to them. So then my setups aren't perfect. They're all over the place because based on what I see of what I need to do for the patient, that's what's going to enter and reduce your damages, complaints, sores, etc. You'll reduce it. That's what provides adaptability. Remember, I'm asking you to change. 8, in 2019, pardon me, the International World Health Organization listed burnout as a disease. And so we all make jokes about it at coffee break, at courses and conventions when we gather about being burned out, or our patients and they're crazy and all of this. You guys, it starts to add up over a career and over time, and you get tired of it, and you get tired of listening. The dentist is always the same complaints, and the patients, it's always the same complaints. Look, burnout, it's repetitive problems with the patient due to a locked-in bite that causes us stress. When you apply Freedom and Centric, you also benefit your patient and you. So you become, again, burnout is when you become disinterested in your job. you've lost that fire in your belly about what you do. That's burnout, everybody, because you deal with the same BS every day. And we do that over a course of a career, it adds up. And this is to, again, spark you back to say we can do better. When you use denture teeth like VITA that have the freedom in Centric, you start looking at a chew cycle and you start looking at a person. So again, I'm confident that most of us will have some cases in our office right now that are driving us nuts. And so the first thing I want to do now is to have you go back and rethink that patient. I had a fella in my office not too long ago, actually, came in with a bag full of teeth. Don't you love those? And he's like, you guys don't know what you got. None of you guys know what you're doing. I'm like, okay, well then why are you here? Well, because he still needs to eat. So I started talking to this guy. His wife's in there in the treatment room as well, because this is a problem for their life and quality of life. And after talking to this guy, you know what I found out? Not only does he have a bag full of dentures, but he can feel, when he goes to bed, he can feel a crumb in his sheets. Now you can think this guy's crazy, but they actually vacuum their bed out every night before they go to sleep so that there's no crumbs or particles in the bed, because he can feel that. So I looked at him and said, well, now you understand, why do you think you have a bag full of teeth? Because he's that hypersensitive. If he can feel something on his skin, touch his skin, and drives him nuts, what do you think a denture's doing in his mouth? But what happens is now we can manage that and try to build the denture with education with the patient as well, so he understands it and accepts it better. And now he's going to stop the comment of none of you guys know what you're doing, because he understands that I caught it. I caught what the problem is. This guy's hypersensitive. He's allergic to the world. Everything bugs him. He likes to wear loose clothing, doesn't like pressure on his skin. What do you think a denture does in your mouth? It puts pressure down. So you think I'm going to open the vertical all the way on him and increase his pressure? No, I'm going to rethink that treatment plan. This is what I want you to do. Take a look at a patient. Who are you building this for? Okay, so that's why I'm asking you to try VITA. The type of teeth you use matters. And that's why, again, I'm here to help, and VITA's here to help support and foster a relationship with you, and ergo the patient that places their trust in you. So thank you for investing in yourself. As we wrap up the PowerPoint end of this, and I'll jump into now how to set the teeth, I wanted to show you that why aspect. So Jim will have access to this as well, and since we are recording it, but this again is the list of all of the territorial reps for you in Canada and the US. And then if you're outside Canada and the US, you can certainly go to VITA.com, VITA Zahnfabrik, and you can find that out as well on their lists of how to get a hold of them. So this has been my journey, and now my better journey with VITA teeth. So now, instead of the PowerPoint, I'm going to show you more, okay? So bear with me as I jump screens, and I have to go and turn the camera on. So thank you for your patience while we do that. Takes a minute to load. Okie dokie. And we're going to do this, and da-da. Okay. Hi, everybody. Can you see me now? There we go. All right. First thing is I want to start with this, okay? So let me let's turn the light off. Okay. Here's a lower, here's the upper. Now these are molars. So the first thing I want to review again is the centric. So the way VITA teeth align themselves is that the teeth come into contact, and then again, we have that 1 millimeter space right here. Generally speaking, you can have contact up here, and then again, that space will be here as well. But generally speaking, you can tip off, and we don't have that contact. Okay, so the reason why I'm going to do that is because, again, the idea behind VITA teeth is that they're mortar and pestle. It's a pulverizing tooth. 20-degree teeth you have to touch together, and they have to mill. So you're doing this, but when you do this, you're putting a lot of horizontal draw onto that denture, and it's going to tip. This way, the bottom comes up, and it contacts, and it is pulverizing and crushing the food. It's a little bit of a different pattern and chew cycle. It's creates more stability that way as well, because I don't have to mill it and create more of a horizontal pattern. This operates better. So lingualized occlusion or lingual-formed posterior denture teeth are superior, and they've really helped me in my career caring for patients because of that. They mince food. And now I'm not getting the problem where patients are complaining, saying, well, I can't eat lettuce, I can't eat lettuce. They're able to crush the lettuce now. We've taken care of that problem. I just had to switch the denture teeth. And ever since I've done that all these years ago, here I am today, and it's working better. So this is the nice thing about it. You have that freedom. So we have that ability now to do this, okay? So now you understand that I can take this tooth, and if I line it up in the middle, I've got a degree of freedom. But I can also take this tooth and move it. So I can move the upper and the lower positioning in here as well as I need to. Because before, when the denture teeth are locked together, if you move one, you're moving the other. Well, now that's not necessarily the case. I actually have a degree of a millimeter that I can move one or the other within that pocket, within that helicopter pad. And then if I have to, I just have to grind the guiding planes to watch the hit and slide. And then I'm able to do this and modify the top tooth and change its arc and angle. What does that do? Well, that also pushes the cheek out. It also helps if I have a cheek that's nipping in underneath, or the linea albicans, the line on your cheek that people like to nip. This allows me to be able to adjust around that. So I don't, because the teeth aren't locked together, I have a lot of freedom here of what I can do specifically to that person. So remember, now we have the chew cycle. So now it's identifying that chew cycle, and then it comes in, and now you have that freedom. And so now you also want to watch the hit and slide. So that's the guiding planes. Okay, buccal upper, lingual lowers. So you want to watch these guiding planes so that then you want to watch and check to see if it's hitting on those guiding planes. So yes, I'll show you how to do that as we move through. So this is what's really important, is I have that ability now to not only take this tooth and move it and leave the upper where it is if I need to do that. If I need to stay over the ridge, but the upper I need to move. Everything's not locked together anymore. It's far less grinding. It's far easier and far less stressful for me as a practitioner in setting the denture teeth. And especially now that we get into these class 2 and class 3 cases, it works really well. And that's what I wanted to show you with this example. Again, you've got the chew cycle, you've got the freedom, but now I have the ability to alter and move things because it's not locked together. So that's really important, okay? So moving on. So again, how this works for lingualized and for VITA teeth, okay? So how this works, you have a cusp tip. So the cusp tips are here. So that's what's going to pulverize the food, okay? These guys right here. And then they rest, and I'll turn the light back on. They rest into these fauces here, okay? That I'm going to touch with black. So that's how out of the factory they want you to do it, okay? So bear with me on that statement, okay? And now, these are the guiding planes. So I'll color it with a strip, okay? And that's the hit and slide. So again, going back to the large teeth, okay? So that's what we're looking for here. When you set these teeth, they're not locked together. But what does that mean? Is it's also not knuckle tight. You're going to see gapping involved with the teeth. And that's important, but it takes a while to get used to it. When we do an in-person denture course setup, everyone wants to do this and have it knuckle tight. No, you have to learn to open things up and let there be gaps in there. So coming back to this, you'll see that you want there to be gaps and spaces in there. Because remember now the chewing videos. You want the chewing video everything can't be locked together because it has to go through that cycle, and everyone's cycle is different, and then it can be manipulated as well through what you're chewing. So the whole idea of having all your denture teeth touched together, and again, everybody, bear with me, but I remember in school, and they take that paper, the onion paper, the real thin paper, and they would touch you touch the teeth together, and then they'd pull the onion paper to see if you had contact, and then working and balancing contact. Remember those crazy days? Nobody chews like that. It doesn't work like that in the real world. Sorry to everyone and all my educators. I'm not meaning to, I'm disagreeing, but with respect. It doesn't work like that. You need to have that open. It needs to be free. You got to watch the contacts. Okay, I'm going to switch back. There we go. All right, so I wanted to draw that on the teeth. So now we're going to cycle over to our model that we're using here today. Okay, so there you go. So we're going to try to make it as pronounced as possible. And again, please understand that I apologize. It's hard to do some of this stuff with cameras, and certainly it's always easier in live courses. When we all get to travel again, please request courses with VITA and Jim. And I'm glad to come out and do this in person with you, privately or in a group setting with a course. I can come privately to the lab or denture clinic as well. So these, situations here with a class 2, we get a little stressed because it's like, well, how am I going to fit teeth and how am I going to make this work and function? Understand that your function and most of the function is chewed on the molars, which is going to be right in this area here. This is where you want most of your function to occur. So what we're going to do is identify tooth position. So if you bear with me. Okay. So I am still here, but I'm looking for a new pencil because the other lead broke. All right, we're going to do it this way. All right. So the first thing is to do some model analysis. So I'm going to outline it, and we're going to come through and we're going to circle the incisive papilla. So what that does is that shows us clearly where the incisive papilla is, and then we're going to cut it in half, like a cross. Okay. So what that's doing is setting the midline and the surgical midline of that patient. The other thing that we're going to do now is we're going to find the long branch rugae. So typically the long branch rugae is right here. And this is important because at the end of the long branch rugae right here through my crazy drawing is that's where the cuspids are going to be plus or minus 1 millimeter. So that's important for you to, as a technician or as a denturist setting up, when you set the anterior teeth. So what it's doing is it's pointing me in the direction of where I'm going. So it's nice to do that because then I know that my cuspids are in the right position here because they're at the end of the long branch rugae. So that's the beauty of it, is everything should follow. So when you do a setup, that's why you see I've cut it out, and I try to cut things out so I can orient where I am. And then I know where I am, because then skeletally, I know that these teeth are in the right position for that patient. So it's one of the things about model analysis is it lets us know where the teeth go for that specific arch. So then again, we would circle the tuberosities here for us, okay? And then that gives us some of the key points. So we know long branch rugae, we know then where the cusp tips go, we have the central line for the patient, and some of you you can draw down here as well, okay? and then that helps us orient where we are. And then on the lower, okay, we're going to circle the retromolar pads. This one got a little bit cut off. Okay, and then we're going to come around and we actually can try to find the frenum to come up, and then that's where the first lower premolar or bicuspid comes. So when you come up from the buccal frenum up, and sometimes they're hard to see. So typically these dots are where we are located. These dots are where the first premolar or first bicuspid goes typically for a patient. It's typically right on the arch. So right when things curve is where that first premolar goes. So it gives us a little bit of orientation of where we are. I'm not so much concerned anymore about what the crest of the ridge is and where the crest of the ridge is. With model analysis, I'm looking at structurally and skeletally where the bone is underneath this case, not what the ridge looks like. So again, we used to, when we went to school, it better be over the crest of the ridge or you get your butt kicked and you fail. I disagree with that now. The crest of the ridge has nothing to do with how I set my lower teeth. I'm setting them over model analysis and where the skeletal system and where the bone is underneath. So to now orientate ourselves, get the upper model back in here. Okay, so I've set the 6 upper teeth up. So I'm going to back up a little bit. And I've set the 6 upper teeth, okay, on the articulator. Let me take the pin out, okay. So I've got 6 upper teeth. I'm going to go side profile without the pin so that you can kind of see where we are and you're thinking, yeah, that looks about right for Monday morning, okay. So these are the fun cases of where we get to sit, okay. Now, without pictures, without knowing the patient directly, if it's just for a dental office or a doctor, we have to go with what the model analysis says and the skeletal system says, and then we'll have to adjust it on a wax try-in if they don't like it. If you know the patient, then I already know where I'm dealing with in terms of the positioning of the teeth for their chew cycle and things, then I have some ability to alter that, okay? So next, so we're going to come in now and I'm going to, let me just back up here. Okay, so I made a little pad now for the bottom. Okay, I'm going to take the pin out so we can see better. And now I'm going to close this up and I'm going to show you what I'm doing. Okay, so I've set the lower and setting the lower. Okay, now to get there, here's the upper piece. Okay, so the first thing we do is I want to set the upper first premolar. Okay, it's always this tooth because then that helps me dictate to set the lower. So the idea behind this now is that this cusp tip, so the lower cusp tip here will come in and rest into the upper mesial fossa here. Okay, so that kind of gets me centered and going here. Now, from the position, I am a little bit buccal of the ridge. So I'll show you there inside. I'm a little off the ridge. This ridge tapers quite a bit here in the anterior region. So I am, from a technical perspective, I'm over my dot. So I'm over my dot, but remember I have about a millimeter window tolerance over that dot. And so when you look at where I am over that dot, okay, there I am, I'm within that tolerance. Remember, there's not a lot of contact that I'm going to be delivering here. Most of my contact and pressure is designed to go here over the molar area. So isn't that interesting that you do model analysis we do model analysis. I've done model analysis. I've set the position of the upper cuspid. I've set the position of the first premolar. And look, when I set the lower first premolar, it automatically centers itself over the dot that I drew. Isn't that interesting? Everything is mathematically equated, everyone. It's golden proportioned. So I'm within the tolerance zone level. So the idea is then that this red cusp tip comes into this fossa. So that's how we'd like to set it up in a perfect world, okay? Like this, okay? And you'll notice there's going to be a slight gap right here. That's fine. This little gap is okay, okay? And that there's this gap between the mesial or the distal here and the mesial here. It's not locked in. So when you are used to setting dent supply teeth, and I'm just going to take this off and show you, we typically want to see it like this. You want it right, sorry, the tooth is loose. We typically want to see that thing right in, knuckle tight like this. And I'm asking you to set it like this, okay? So there's a reason for that. What's the reason? Well, the reason is, remember, we're not going to lock our teeth together. We're going to be more open with our bite and how things line up, okay? So, because everything now, the lower jaw is most posterior. In a lot of cases, typically too, the line here and the lip, the orbicularis lip, is really tight. And we don't have a lot of play, and it's a real tight lower lip here. So we don't want bulk here. So that's the idea where I can come in now and really angulate the teeth and fill this up so that we can have at least not too much of a gap from in terms of an over jet and an over bite position when we set the lower anterior teeth. So that's why this lets me kind of pull things back a little bit so that I have some room. So that's one of the reasons why then we're going to follow this. Okay. So next, we're going to set. Okay. So typically we come in and we set our molars. Okay, because we're not going to set usually a full complement of teeth. There's usually more teeth on the top and less teeth on the bottom is typically what we see. So we'll follow this on this arrangement here. You have to appreciate that every arrangement is going to be different, but I wanted to show you now that when we set now, okay, the lower teeth are going to be set on a flat plane. So we're coming through. We can do a slight curve of Spear-Wilson if you wish, but typically they can come and set flat. So now, because we're typically lack of space issues, the lower molars are going to be over the crest of, over the deepest part of the ridge. And now we have the upper teeth, and they rest in like this. So typically for a class 2, we have some flexibilities. A lot of times we can try to get the 6 complement of teeth. It might be difficult to get the second premolar in because of space issues. So what I wanted to do on this setup is to first off just show it without the second premolar, show that you see that it's not knuckle tight. Okay, there's spaces and gaps in there, and that's again to allow for the rotation and movement then of, you can see there, okay, because now you're going to remember that this patient's going to come through and they're going to go through a chew cycle, right? And so now this is what I'm trying to mimic. So what you're noticing now, just by me not even thinking about it, it's become muscle memory for me. You see how I didn't do this? This is what we're taught in school, and how most of us manipulate an articulator is we do that movement and we're checking for working and balancing this way. What did you just see me do? I did this. What am I doing? I'm trying to manipulate and facilitate a chew cycle of a patient. Look at that. So that's what I'm trying to do. I'm trying to now imagine and facilitate a chew cycle of a person, not this. Nobody chews like this. This is not how you see it in the real world on a chair, in a chair with a patient. The patient's going to chew like this. They're going to move. And if you give them gum, or you give them some cucumber or some green pepper to eat, this is what they're going to be doing. They're going to be moving like this, and this is why I move an articulator like this. So now what the key points are to review when we're dealing with a class 2, okay? I have, these are my cutters. These are, again, the cusps. And they're going to rest into the fossas, okay? This is what I would like to see, okay? So I have the red dots into the black dots. That would be ideal for me to have done. Now, typically you want the tooth over its counterpart. I want the first over the first, the second over the second, the molar over the molar, second molar over the second molar if we can, in a perfect setup, in a perfect world. How perfect is your perfect world on Monday morning? Not. Okay, so, all right, I wanted to show you the ideal. I wanted to show you what it looks like with some spaces. I wanted to show you what happens with the gapping and the contact of where the cusp tip is into the fossa. So I did one side kind of quasi, ideal and what you'd like to see. So let's do the other side. So I'm going to take this off, okay? And now let's play around a little bit, okay? So what happens now because we have lack of space? So typically on a class 2, you have lack of space. So what I've done is I've now on this side, I've set the upper first premolar, okay? But now on the bottom, what I've done is I said, okay, what happens if I don't have space and I can't set the lower first premolar? I'm using a second premolar. So what I did is I've used an upper first premolar here, but a second premolar here. So now I've changed. What have I done? Well, now I've taken the cusp tip here and I've placed it where? I've placed it. You can actually see the dot from the pen. That's why I love using these pens instead of articulating paper. So I've actually placed it right there. Well, wait a minute. You just said in an ideal world, this is what you'd like to see. Yes. Oops. In an ideal world, this is what I'd like to see. In an ideal world. But now what am I showing you? Because the teeth aren't locked together, because you're dealing with a cusp tip coming into a fossa, it's not mandatory that it has to go over its counterpart. I actually now can take an upper first premolar and land it over the second premolar. Why? Because this has a cusp tip, this has a fossa. What matters is you put a cusp tip in the fossa. So now for an example, I've done 2 more second molars on this side. So I'll bring it up and into focus. I've done 2 more second premolars on that side. But now let's switch out the top. And what have I done on the top? Well, I've gone a little bit more traditional and I've put in a first, second, and a first molar. But look what happens when I lay it in there. All I've done is, okay, it looks a little unorthodox, but what that's only by view. Function-wise, I still have a cusp tip here, here, and here coming into the bottom. Look, it marks it. So now the cusp tip hits here, and it rests into that fossa. So you guys, we can't see every jaw relationship. What I want to show you on a class 2 is that it doesn't matter what tooth goes where. You got to make it work. But I'm setting this up without grinding my fingers to the bone. I'm not having to alter things because the teeth aren't locked together. I'm actually able to take it and manipulate it and move it so that a first premolar sits over a second's over a second, a molar's over a second premolar. It doesn't matter. You have to make it work for the space. What the teeth do is they give me the flexibility to do that, and I don't have a lot of grinding to do because I'm still sticking a cusp tip into the fossa. And it still works with working and balancing because that doesn't change. And it still works from a working and balancing perspective because that stays the same. And it still works from a chew cycle. Okay? Nothing's changed. But what have I done? I can't do that with other teeth, with other manufacturers. I can do that with VITA. And I can do that with these teeth. Okay, my list of teeth that I can have this type of flexibility with is really small. Okay, and that's why I have found and profoundly has impacted my career is using these types of, because at lingo form from VITA is because I'm able to do these types of wonky situations but make it work for the patient and what works for the ideal. Okay, and having that in there. So what I wanted to show you was on one side, we have, the more traditional setup, okay, where a tooth is over its counterpart, and that's fine. We can have that. Okay, just like this. So on the right side. So what I would like to do now is, bear with me, I'm just going to clean the teeth and then I'm going to show you. Okay. Sorry, there was no hold music there. Okay. You don't want me singing. So, oops. I use a Staedtler non-permanent Lumicolor pen. So you have to do non-permanent. Made in Germany. Okay. So what I do is I take it and I'm going to color the cusp tips. So remember, these are my cutters. Okay. In a normal situation. Okay. And then I'm going to put it into contact. And then I'm going to open. And now you can see it's marked it for me. And it's marked it of where the tooth is hitting into the fossas. You can see the little points there. This is more accurate and finite than articulating paper. The trouble with articulating paper, and as I grab a sheet here for everyone to show, articulating paper is really thick. Even the thin stuff is thick. And what happens is the paper bends between the teeth and you get wrong, erroneous readings. Okay. I like to use this because this is tooth on tooth contact with this pen. It's given me the raw data of the tooth unmanipulated. Okay. So what that does then is if I close this up, okay, so what that does now is if I imagine a chew cycle and I imagine now trying to eat with this and a chew cycle, what that's going to do is you can see, focus, there's a red mark right here. So what happens is it will now rest on planes and I'll get a red mark on the guiding planes. You also can then look up on the tooth itself and I can see that a little bit of the ink has been displaced here and moved. And so I know that this cusp is getting contact and it's getting work. And then I can also see then on the fossa on the bottom, if it's hitting the guiding plane and then sliding in, when I do the motion of the chew cycle. So what am I looking for then when I do this chew cycle is I'm checking to see then if there's a hit and slide. So what you can do then is I take green and I'm going to color the guiding plane. So buckle upper, lingual lower. So I'm going to call it out right now, everyone. When we went to school, they told us that there has to be contact buckle upper, lingual lower. And now I'm saying no. There does not have to be contact buckle upper, lingual lower. And what happens now is I'm going to go through a chew cycle. Okay. And now I'm going to be looking to see if I see any green marks on any of the opposing teeth. So sometimes you'll see them right in here. That's very, very common. Okay. And so now I'm looking to see if I see any green marks, because then that's the hit and slide. And then I can adjust that and manipulate that there a little bit if I have to. Again, with a rubber wheel or a fine burr or stone. That helps me. Okay. The other thing is to keep in mind then, if you say, well, geez, Mark, let's look, for example, and now this first premolar that you have here is too off the ridge. It's not good. But remember, because this tooth isn't locked into the upper one, I'm actually able to then heat the wax and shove this tooth in. And what that's going to do is, all that's going to do is just move the tooth within the fossa a little bit more lingually. And then I'm just going to have to grind the lingual of the guiding plane a little bit. But the upper stays where it is for an aesthetic position, but then the lower I can manipulate in for a function consideration and not wreck any and not damage the teeth. Because again, the cusp tip sits in the fossa. The fossa has a millimeter of play to it. So then I'm able to adjust things and move things. You can't do that with other denture teeth. So when you're dealing with these types of situations with the class 2, that's where it really becomes its value, is when you're dealing with situations where I have to make it work. So now on this side, I have to make it work. So I wanted to show you, you can alter them, put whatever teeth work in there to make it work in there to make it work. That's good English. Whatever teeth that are necessary in there to achieve the case results, it doesn't matter. I'm not grinding them. I'm not having to manipulate them, because that's how flexible they are. I just have to watch the guiding planes afterwards for function. So that's the beauty of this, dealing with these types of situations and a class 2 situation where we might have more space up here, so I can put in an upper second molar, but I've really short spaced on the bottom, and we're trying to fit molars in. If you can't fit it in, don't fit it in. If you can fit one in, fit one in. It doesn't matter. All I'm looking for is that appropriate cusp is sitting in the fossa of some kind. That's all that matters with this. That's the beauty of the teeth and how they're engineered. So circling back, I'm going to wipe this clean. I'm going to show you something else. So Jim, I have a question.
Go for it.
Are there any questions in the question box, Jim? Because I can't see that.
There are. We've got several questions, and
okay.
I assume when you're ready,
I will get to them. Now,
yeah.
Thanks, Jim. Okay, I'll circle back to you right away. So now, I showed you how I check this in the lab, and that I use these pens instead of articulating paper, okay? So what do I do intraorally? I'm going to take the denture out. I'm going to dry the surface of the teeth. And I'm going to take a Q-tip or a cotton swab, and I'm going to place it in petroleum jelly. Okay, so Vaseline into petroleum jelly. And then I'm going to take it and I'm going to rub it onto the articulating paper. And now the ink of the articulating paper is making the Q-tip saturated. And then I can go, and then what I do is I can do this and I can color the cusp tips. And then I would insert this into the mouth of the patient, and then I would get them to talk. So remember, days of the week, months of the year. Because what's going to happen, they're going to say days of the week, months of the year, it's going to function, and then they're going to touch together in centric and swallow. So what's going to is this will be functioning in the mouth. It's going to be moving in the mouth, functioning in the mouth, and then I'm able to take it out, and then look what I can see. I have all these dots, whoops, I have all these markings now on the fossas, and I'm able to check that with the patient and then understand. So what was the patient's complaint? Is there a sore? Was it moving? Is there food going underneath? And then I'm looking to see if it's hitting on an offending guiding plane or not. I'm looking to see if there was contact in centric, because they're giving that information to me organically. When you take articulating paper and you stick it in someone's mouth, the first thing it's going to do is retrude the tongue. The tongue comes out of the way. Game over. Your bite's wrong. Okay? You have to get your hands off a patient. Don't manipulate the data. And this is how I've come up with this, is to get this information, and then there it is, and then I can remedy the problem based on what is the problem. But it's showing me organically how the teeth were functioning. Isn't that awesome? So, Jim, hit me with some questions, please.
All right. So we've got several questions. One's going to be, what are the markers that you use? What are the name of them?
Okay, I'll come right back. There it is. So Stapler non-permanent Lumicolor. So go just get anything that's non-permanent. Sharpie non-permanent is fine. I just took Stapler because it was made in Germany, and I'm a little biased. But you can use a non-permanent Sharpie marker as well. And then I got them in these cute little packs, okay, of 4 different colors, okay. And I bought it at
non-permanent, right?
Non-permanent, please. Yeah. Okay. And I got that in we have Staples up here in Canada, so I got it at a office supply store. Okay. So that's the name of the markers. So that's what I use in my office. Now you can't use this in the mouth because it'll bleed. So that's why I've gone to the Q-tip and the articulating paper to do the dots interoral for me for a patient. Okay. So if you've got a patient that's breaking cusp tips, then you're going to want to color the bottom cusp, the bottom anterior teeth, get it in, and then you're going to see these little marks come up on the top. And then you know you need to adjust and allow for more clearance. Okay, by having the patient say days of the week, months of the year. Okay, Jim, next question.
All right, do MFT teeth, the economy teeth, have Freedom and Centric design?
Yes. Yes, it's a premium tooth at an economy price. It has Freedom and Centric. Yes. You can do the same thing with this, of what I'm doing now with Lingoform. Yes, 100%. Same idea.
Oh, this is a good.
All you're doing is putting a cusp tip in the fossa. But remember, MFT is acrylic. It's not acrylic glass, so you have to polish it after. Okay. Go ahead, Jim.
Oh, this is a good question. Since we often do post check, bite check
Yes.
after you process it. So the question is, how do you prevent removing the Freedom of Centric when you post-process or equilibrate?
Okay, so when you remount and you're going to touch up the occlusion, what you're doing is you're taking and you're reaffirming the red cusp tips into the fossas of the teeth. So you'll want to touch that up. So you don't want to touch and grind the red cusp tips. Leave those alone. You're only making the correction of the fossas of the bottom. And so then you're adjusting the fossa. So if I can, I'll just circle back to here. So you're going to want to leave this cusp tip alone. And when you're doing your correction, you'll be checking and adjusting this point here. Pardon me. And when you have that done, then you're going to be checking for any interference along the guiding planes, buccal upper, lingual lower, in these areas here. And then you're going to be checking for that. But the first thing is to reestablish this. Jim, does that answer the question, do you think? Since I can't ask that directly to the participant. So
yeah, but you spot check it and yeah.
So but do not touch the cusp tip. You touch and make the correction on the fossas. Okay? That's the beauty of this. Then I'm only touching the fossas. Okay? All right, Jim, next question.
I think you kind of answered this earlier, but the question is, can you do this setup technique with VITA MFT teeth?
Yes, 100%. It's the same concept, okay? Put a cusp tip into the fossa. It's the same idea. Okay, and then, where the change is just, I was going to say, where the change is the material. It's acrylic. Okay.
Can you do this technique? Can you do this technique on an upper denture with opposing natural lowers?
Yes. Gets a little complicated, but yes. So now what's going to happen is you'll have the cusp tips sitting, pardon me, into the fossa of the lower occlusion-ish. Okay. So that's then the only time I'm going to give you permission to then, you might need to take this cusp tip and just dumb it down a little bit and flatten it a little bit. Then you can do it. But then when you're doing it, you're also then checking again, buccal upper, and then you're going to watch, because again, there could be some contacts here, just on the side of the tooth there. Okay. And then that's when you can go in and do that change for the upper as well. And then to get the freedom, that's when you might also then just have to thin this cusp. So let me just switch and show you on the upper here. Okay. So imagine now that this is lower. Here's the cusp tip. I might have to dumb that down slightly or change it slightly to fit into the contours of the lower natural tooth. And then to get the freedom, I just have to grind this, the guiding planes here, thin this down slightly to get my wiggle there. So then the answer is yes, it's the same principle. Just I'm making slight corrections now to the upper. Okay.
All right, good information. So someone's asking, well, what was the most extreme case you've ever had to work with to bring maybe a class 2 or class 3 and get it close to a class 1? That you want to describe one of your worst cases, your hard one.
This one. So what I did was, so anyone that has taken a freedom course with me will recognize these models, because you actually do the setup on this. But that's the actual jaw relationship of this patient. So this patient broke their right condyle. And so then what happened was they fell on the sidewalk and they hit their jaw, and the whole mandible went up and back. And so now we're left with about a 10 millimeter. So the whole jaw went back 10 millimeters and then as a result opened. So our actual distance here is about 55 millimeters, and now it went back about 10. And I turned this into a class 1 because this lady didn't want to look deformed. So this is the full-on case that you do with me on a hands-on case on day 2 on our 2-day freedom course. I've done this conventionally, and now we've actually did this digitally. She came back and we've actually done a digital denture for her, broke all the rules, okay, and actually really had to have some fun with this digitally about how to, again, achieve our treatment goals with her. But this is by far one of the most complicated cases here that I've ever done in my career, where we've turned a class 2 into a class 1. She has no functioning right condyle, so her bite cycle is absolutely insane. I have the videos of it to show how wonky it is. We had to give her lots of freedom. This is the prime example of why you use these denture teeth, because they give you the platform to work on and the freedom to work on. And that's why I wanted to show you this, because it's an ideal case as a class 2, but then to show you, okay, you can set one side in quote unquote a little bit more of a normal position, but then on the other side, or in any situation, all I'm asking you to do is take a cusp tip and stick it into a fossa. Again, I sound like a broken record, but you can't do that with other denture teeth. And that's why these teeth are awesome. And that's why I use them. They have helped me tremendously in my career. And then in helping patients and treating patients, it's been honestly, it's been awesome. I've been awestruck by it and learned more about how the teeth function and how to manipulate them even more. But this case here is the kicker. Certainly the one that I travel with globally as well to show people. And then now the fact that we did it with Vigo, with the digital tooth line from VITA, is phenomenal, that we could manipulate the software such that we could actually achieve these results. It's pretty awesome.
Yeah, it's a good point, because we have you know, more digital work we're doing today on prosthetics. So
correct. And so it's been real cool. I've got some cool pictures. So once I get back on the lecture circuit and you come see me, I've got some pretty cool stuff. But you know, again, this is about being someone's superhero. You're trying to be your patient's superhero, and you're trying to get their function and dignity and quality of life back and chewing life. And so let's not complicate this. I need to use product that manipulates and forms to the patient. This isn't about me. This is about that patient in that chair over there. And what's important is I just need to mold myself to them. So that's why I ask, I look, I check what's their cycles, all of these things, so that when I sit here and I set the teeth, I can adjust and set. It's awesome. And all I do is I manipulate it to the person. It's no extra work. And you can see all I'm doing is just sticking a cusp tip into a fossa. It's that simple. And it's less labored and less stressful for me as a practitioner by using this product. And that's why I'm here. And that's why I want to give back to my professions that I love so much, to share with them my journey through my career, to help lift us up even higher and ignite our spark again. If you guys are feeling a little down, and it's been a tough year and you're feeling a little down, this is to get you back in love with this stuff. Dentures isn't the end of the road for somebody. They can function and have a quality of life. It's doable. Just have to, again, not make it as complicated. It's just sticking again, it's as simple as sticking a cusp tip into a fossa, and then just make sure it works within the bite cycle. That's why I love these teeth. It's less complicated. I sound like a Levine. Okay.
Here. No, that's good. So have you ever been forced to have a case where you have on one side a class 1 and on the opposite side an end-to-end?
Yes. And that's where these teeth have that ability to function. Because again, because I have that wiggle room, and remember, freedom is good, and I have that wiggle, then I can just take it and I can adapt and move. Yes. The answer is yes. And it's not daunting anymore, because now I have the teeth that can allow me to manipulate and move in these types of more complicated situations.
So as far as the articulator goes, you want to explain what articulator you're using, and the question really is, there's someone that's using a Stratus 300, which
yes,
I personally don't know if it does a immediate slide shift or not, but
it does.
They want to know if they can check for freedom and Centric with that type of
yes. So
articulator.
you have to use, this is a Cavo Protar 7. So a 7-9 will do it. Okay. So that's this articulator, and that's this setting here that adjusts the freedom and how much wiggle the articulator has. So that's how it's done on this articulator. So that's this adjustment here. So it's a 7 or 9 Protar. A Stratus 300 will do it, Jim, 100%. It's one of the little screws in the back. I can't remember which one that loosens it, and then it'll do this. Okay, so a Stratus 300 will.
Right.
A whip mix will do it with, I think you need the insert. A Danar does not. It's a pretty shallow list.
All right, great. So next question is, how do you orient your lower anteriors to ridge? Are you comfortable angulating them quite far anteriorly?
Yes.
Or closer to the lower ridge crest to prevent forward tipping?
Yes. So typically, to answer that question, and let me just, I'll take all my little pieces off here. So let's snuggle in here. Okay. So yes, I can do tipping. What I'm looking for though is how tight is this attachment here of the muscle coming into the sulcus and the orbicularis. I'm looking to see how tight this is. If it's real tight, then you're going to have to come in at quite an angle so as the lip doesn't manipulate the denture, shove the denture and lift it. So you're going to have to see how much room you have in here. If you have if you don't have that information, you're going to have to call the dentist and ask for them to check that. If they can't give you that information, then I'd always err on the side of caution, especially on a class 2, and say that this is going to be really tight. And then you do want to angulate, have the neck in close, and then angulate the incisal edge out to what you deem is reasonable, and then check it in the wax try-in and check it again.
Oh, you've frozen. Are you there?
Ask the dentist to take a video of it, and then you look at the video and make the assertions yourself. I am.
All right.
Is that better?
And then, yes, it is.
Jim?
Yes. Can you hear me?
Okay, so again, and then again, I want to do the days of the week and months of the year to again check that in the mouth to see how that phonetic is working within that patient's chew cycle. Okay.
All right. Can you hear me?
I hope that answers that question. I can.
Mark? All right. Great.
Yes.
So another one, kind of related. How do you tackle the issue of a deep bite in class 2 when you have to place lower anteriors more lingual and high on the occlusal plane to get the bite anteriorly and maintain lateral excursions?
Right. Okay. You know what? Let's draw it out, okay? All right. Here's your upper. Okay. Now you said deep. Okay. So let's go lower. Let's do this. Right? So I'm assuming that's kind of what we're after here. We have to go pretty deep. So what's the factor and what's going to check it for me now is this distance and the movement of the jaw. I am not going to check this on the articulator. This has to go in the mouth because on the articulator it's going to bind right away. And so you think it's wrong, it's wrong, it's wrong. I have done cases, honestly, where I've got 6 or 7 millimeters of overbite, yet it functions in the mouth because of the way the jaw postures forward and back. So it's doable, everybody, but you have to check. And then if it's necessary, so again, you're going to check with the Q-tips and the articulating paper and the petroleum jelly, and you're going to coat it. And then sometimes where you're going to see is I'm going to get some contact in here. Okay. So then I'm going to thin this because the lowers are already a little bit thinner. So I'm going to thin first where I have the room. So I can thin in these areas here as required. And then if I have to, I can thin a little more to get a little more space. And then a lot of times it's angulated because as the jaw comes forward, it thrusts down. So I would adjust in these areas here. So that's where I'm looking. And then I'm going to use the Vaseline and the cotton roll and the articulating paper to coat these areas here, or coat this and then check to see if it's knocking anywhere in here when I do it. So that takes us back to those videos with the patient. So if you allow me a moment to switch, so bear with me because I have to close this program to make it work. This lady, oh, this one, she's actually got a real deep overbite on this case. So this is why so what was happening is she was coming to me and saying, well, Mark, my denture's loose. On the left side, so it postures out to her left. Whoops. And so that's what I was checking. Okay, there we go. So I was checking, okay, on the her left lateral and cuspid on this case and making those adjustments there. You can see where she just closed, just at the very end. Here, let me run that video all the way. See, you can start to see where she comes into Centric. She's got a real deep overbite there. And so you can push the limits on this. Where you push is, again, checking. You have to check it in the mouth and you have to check it the way I've showed you to check it. And it allows you to do it. Okay?
All right. Next question is, have you ever used Swiss Dent teeth?
Yes.
And any comment on that? Or
way back when, right. Yeah, when I was younger and had less gray hair. Look, it's a form of lingualized occlusion, and it's fine. Follow the same principles. What I'm teaching you here, you can take into other tooth lines. You might have to grind some more. You might have to manipulate a little more, but it's doable. But that line is based a lot on Gerber, which is what the VITA's line is based on. So there's a lot of the similar teachings and underlying tones and theories there. So yes, it works. Okay.
All right. And have you ever utilized an anterior bite ramp for a class 2 overjet situations?
Yes. Yes, if you have to. Yes. Yes, but it's the same principle. Then check it. Use the way I showed you to check it in the mouth. Okay. It's doable.
All right.
Now, before we go to the next question, before I forget, because we're starting to run out of time, I have some pumice. Okay, it's wet. Okay, you can take it and put it on top of the teeth, because remember these are acrylic glass. And then I can take it and I can, let me open the articulator first, and then I can do this to it. Okay. And what you're going to do is you're going to put a fine high shine on the acrylic glass. And that's what you can do. You can use a nice pumice, but you can only do this on a VITA teeth because they're acrylic glass. You can't do this on MFT. Don't do this on acrylic teeth. You can only do it on this tooth line. You can only do it on lingoform and physiodents that have acrylic glass. And what it's doing is it's high shining and polishing the glass particles. Okay, when you come in there and then you do this, okay, I'm sorry, it's hard to show because and then I'm wiggling it. and I'm taking the teeth and I'm doing this to them, and it's putting a nice little high shine on it. I wanted to show you that, but you can only do that under those specific terms, okay?
Good idea.
Pretty cool. Pretty cool. All right, next question.
Can you use these teeth for in a crossbite situation?
Yes. Guess what we're doing? We're doing a crossbite case, aren't we, Jim? When is that?
I've got a list. As soon as we wrap up, I'll show the list to the audience, and they can attend some additional programs for sure.
So yes, yes, and you can do it in crossbite. And let me tip my hat already to that course. All you're doing is now, instead of the lingual cusp going in the fossa, you're putting the buccal cusp in. It's that simple. It's not stressful at all. And then you're checking it within the bite cycle of the person. It's not a big daunting task. That's the beauty of these teeth. They're point load. You put a cusp in the fossa. Whichever cusp goes into whichever fossa, make it work. So that's why I'm not scared now, and so much more now when it's class 2 or class 3. I'm like, okay, well, I got to deal with this. I just stick teeth in and make sure that there's a cusp in the fossa, and make sure it's working to the bite cycle of that person. You're done. Much less stressful. We have enough stress in our life right now. It's much less stressful. So yes,
that's what we all want in life.
And then I've done that also digitally. Again, class 3 bilateral crossbite. We did that digitally with Vigo and had to play with the software a little bit, but it's absolutely doable. You can do that digitally as well, because again, the platform is the same conventionally or digitally with VITA. You've got freedom and Centric on both platforms. Done.
All right, we just got a couple more, Mark, and then we'll wrap it up.
Yeah.
What's the on a class 2? On a class 2, what's the average? What kind of overjet or overbite do you achieve in a class 2? What is there a millimeter?
Okay. So no, not anymore. And I'll tell you why I'm not going to say that. It's whatever the patient needs on the wax try-in. Now you could say, well, that's a very ambiguous statement, Mark. What happens if I can't check that? Well, that's when you need the video from the doctor. Then if you can't check it yourself, then you can check it in the lab, or you have to try, because again, this is where I here's the context behind that statement. If I say it's 1-to-1, how do I know you're 1-to-1 or you're 2-to-2? It needs 2 millimeters to 2 millimeters. How do I know that? You don't know that till you stick it in here and check it and say, what's the function of this person? Okay. I got a real deep overbite, yet when I'm talking, you can't tell. It opens up and it functions, because again, all those signals are being sent back to my brain, so my brain knows how to and where to move my jaw. It's learned a pattern. Now, when my teeth are removed, those signals are lost. So now I need to compensate for that in the denture. So typically, when you ask me, well, Mark, what are you going to do for a class 2? Sure, you're going to have some more overbite there, like overjet. There's going to be some things that are going to happen with that jaw relationship, but you need to see the person to see how much their jaw moves. You have to, again, if you're as a direct health provider, a direct dental provider, you can see that yourself. If you're a dental technician asking that question, you really need the video, or you really need to go there and make a site visit and check. Or nowadays we can jump on Zoom and the doctor can hold up his iPhone and he does it for you right then and there. And you guys just do a live video chat right there. You need to check it and you need to see the motion, the momentum, and then talk the doctor through it. You want to talk about relationship building and trust building with the patient when all that's going on and they see that all these people are caring for me, man, are they going to be loyal? And then that doctor is going to be loyal to you. So that's why I'm hesitant to tell you 1-to-1 or 2-to-2, because what matters is what matters here. So again, on that other video of that patient that I showed you, I had 4 to 5 millimeters of locked in, but when she was talking, it opened right up. Okay, and only at the very end did you see it kind of come back down. So it's tricky for me to tell you. There's no magic number. You have to check it here, and that's our trouble with dentistry, is that we failed to do it, and then we wonder why there's trouble. So yes, I'm asking you. You have to take that leap of faith forward, and you need to ask for that information. If you're not the one that's seeing it directly with the patient, you need to ask for it. But nowadays, it's really not a problem to jump on a Zoom call and have, or use your, if you both have iPhones and you can do a FaceTime right away, okay, and just check it and have them hold the camera and get that information, please. But that's why you're not going to hear me say it has to be 1-to-1 or 2-to-2. No way. We can't operate that anymore with specific linear. It's to the patient's needs and wants. Okay.
All right. And this other question may be the same answer, but yeah, you probably start somewhere. And the question is, what do you set the condylar angle of the path, the angle at on your?
So generally it's going to be 30 degrees, because that's the standard globally for patients is 30 unless you measure it. So then you're going to have to measure it manually or use a Digma from Cavo. So normally it's going to be set at 30, but whether it's 30 in the mouth and in that skull, probably isn't. So that's why I rely less on what it looks like on the articulator and rely more on how I see it function in the mouth in the patient. But I have that beauty because I'm a wet-fingered practitioner and I get to see the patient directly. But this is why you don't see me pulling out, onion paper or the thin paper and checking all the cusp tips in the lab anymore. That's useless. I really spend time checking it in the mouth because that's the final authority. But I understand your question. We got to run with 30 and then make the corrections afterwards if you need to, if there's an error. But if it's an error and it's breaking all the time or chipping all the time or you're running into those problems, that's what it is. And now I've showed you some scope to try and show you how to check it and check it in the patient's mouth to then make those adjustments specifically for them. Okay? That's
all right. Do you see the lower anteriors in a class 2 on a much higher plane versus the posteriors in almost a reverse curve of speed?
Often, yes. Often, yes. Yep. That's common. Then that's when you want to check again the posture as the patient says the days of the week are 66 and they move their jaw forward. You want to coat those lower anteriors, how I showed you with the articulating paper and the Q-tip to check, because that's often that you see that because the way that the arc goes and then we ramp everything up. Yes. So thank you. I spent more time today kind of showing you on the posterior end of things, but now what again, the context behind what I speak to and about checking it can go also into the anterior. And again, the needs of the patient. In most cases, we're going to go up a little bit higher, and that's common, and that's okay. Because I don't care what it looks like here, I care what it looks like in the mouth. And then what the patient thinks about it. Because they don't care about the technical, they just care that they smile and they can see teeth and they like what they're looking at. So if it's as the participant has asked, that the anterior teeth are above plane of occlusion, so be it. If that works for the patient, who am I to say that that's wrong? Okay? It's not about you. Make it work for the patient, but you need to use product that'll let you do it. You can't lock it in. Okay? Freedom is good. All right? We don't slap teeth together. We're very technical, and I'm opening your eyes and again trying to get you excited again in your belly to go back now and say, wow, okay, I want to try that and I want to push the limits, okay? Because you want to be that superhero for a patient, okay?
All right, Jim. So we're going to wrap it up with this last question, and then I'll go over a few more details for everyone. If a patient has a set of dentures with class 1, and you change it to a class 2 relationship, how long, in your opinion, does it take for that patient to rebound, to have that memory change
Right.
in their system?
So, really good question. And you want another ambiguous response from me. I'm not going to give you to the minute or to the day. I'm going to say 3 months-ish, but how is that patient adaptable and what is their adaptability? So with that said, how old is the patient? What kind of medications are they on? What's their demeanor? Are they walking in the office and always complaining about everything, or are they happy and content? Because if they complain about everything, they're going to complain about the teeth. If they're happy and content, and then you see, I look at their skin, and you want to look, do you see bruising? Can you see through their skin? Is it getting thin? Do you see arthritis? What does their skin look like? Okay. I look at their arm and their skin. That's one of the first things I do in the treatment room, because I'm already looking at their body. So to answer your question, it's a holistic response. I need to know about the person to then start to figure out how long it's going to take them to adapt to what I'm doing. And then if I'm going to make these changes, how quickly I'm going to make them. Do I make them in a matter of weeks, months, or sometimes year and a half of treatment? That's up to you based on what you think that person can handle. And that's, like I said, peeling back to that guy that could feel the crumb in his bed. Man, am I not going to change things on him because he's so hypersensitive. So that's why you need to look at the person. So not only is it about this and the teeth and the flexibility and the freedoms and all of these things, it's about understanding about the denture integration into the body of who you're building this for. And now I understand, if I could go back to the beginning part of my career, a lot of the cases I had trouble with was I didn't understand who I was building it for. I built it to the textbook and what the textbook in school told me to do. And they said, yeah, we're right. No, the patient is. They're the final authority. So I got to mold myself to them. So again, the more you can look at someone and try to figure them out, the better you're going to be in your career and the happier you're going to be using product that adapts. And then again, opening those lines of communication with your doctors. Some may not have time for you, that's fine. You're going to have to find other ways, or try to make as much educated decision on the lab bench. If I don't know the answers, then I'm going to put in more wiggle and more room to compensate. But there are some doctors out there that are going to really appreciate the fact that you're taking the time to say, well, tell me about this person. Show me the videos. Let me see. Because again, you're saving them chair time in the end for an adjustment. And now, again, pandemic speaking and just cost speaking, that's huge. If someone can come to me and say, Mark, I'm going to save you $100, $150 of chair time, you've got my attention. This is important. Open those lines of communication. It's really important. It's going to help you in your career and your professional happiness. And I don't want you guys burning out. All right. Especially now, we've been through a real doozy of a year, and it's really affected us mentally as well. And when we can get after this, it's less stressful at work, and it's a happy place to be. So that's my response to you. Okay, about the overbites and overjets, and now about the adaptability of a patient. And if you change things, give it 3 months, but it could take longer. You need to look and decipher about that person. Tell me all about them. If you guys need me, Jim's going to put up my contact information. Pardon me, send me emails, send me questions. I'll help you through it. I have many people send me treatment plans and case examples, and we can work together to help each other through it. We're here to support each other, and I'm here to support a professions that I love. So we're here to do that. So just, again, understand who you're building it for. Then make that decision. Right. Can they tolerate it? Okay.
So a little bit more than just slapping teeth together, right?
Oh my gosh, we do not slap teeth together.
All right. All right. So we're coming up on the hour. So Just a reminder, the CE, if you're looking for CE, there'll be an email. If you've registered, there'll be an email to that registration email address and requesting you to sign in, get back to the education department, and then they can provide you with the adequate CE. The workshop has been recorded, so you will be able to go revisit it on our website, VITA Learning websites, the Facebook, the LinkedIn, VITA North America YouTube channel, and so forth. So please revisit that, and you'll also find other webinars that Mark has already recorded in the past. You can contact the help desk here at VITA North America. This is the information. Just type in help@VITANorthAmerica.com, and if you need information for Mark, we can provide that as well. Mark showed it earlier, but we do have, on site, out in the field, many reps that are there to help you as well. Again, just contact us, VITA@helpNorthAmerica.com, and we'll get you that, set you up with that specific representative you need. Mark, like I mentioned, Mark's done some other webinars. We got several more the rest of this year. So, his next one's May 25th, June 17th is a class 3, and then July 13th is a combination syndrome. So, go to our website, the VITANorthAmerica.com/courses, and you can sign up for any of those. This is Mark's information here. So feel free to write that down or screenshot it, and you'll have his information. And if not, then just like I mentioned, just give us a call or an email here at the help desk, and we'll get you in touch with Mark directly.
And I'm on Facebook.
I'll leave that on. Go ahead.
And I'm on LinkedIn and Insta. So come find me, and then we can be friends. And then you can ask me questions, or again, that's my contact information. Send me an email or text me. I'm here to help and support you. I'm here to help and support VITA, because VITA supports me. So it's a great relationship. We're here to be superheroes to a patient.
Yes, you are. And Mark, I appreciate another fantastic webinar. This really went well. We had a lot of questions. I'm sure there's more out there. So please email us questions as well. Get a hold of Mark, at his address, at his email. Give him a call, bug him. He's opened it up to everyone. So I appreciate everyone hanging in there for the length of this webinar. But Mark, any final comments?
Thank you, investing in yourself. Everyone, take care, be safe, be that superhero. We're here to support you and build that relationship with you. But remember, the type of teeth you use matters. And it's been an awesome change in my life with everything that I've spoken to you in the last couple of hours. So that's why I wanted to share that, and I share that with everyone as I go forward. So thank you. Thanks for investing in yourself.
And talking about investment, thank you, Mark. Again, there's many courses going on, webinars for the rest of this year with Mark, different topics every time. Please get a hold of us, sign up, enjoy, keep learning. I want to thank everybody for joining us here for another VITA Learning webinar here with Mark Wagenseil. And with that, we'll say goodbye, and I hope everyone has a great day. Mark, you take care of yourself. Be safe. Thanks, up in Canada.
Yep. Thank you, everybody. Thanks for your time. Okay. Be well. We don't slap teeth together. Freedom is good.
For sure. So this will end the webinar today. Thank you very much for joining us.